Welcome back to the Med Student Notes, everyone. I've made a table to compare and contrast the main trisomies that we should know as medical students. Down syndrome, trisomy of 21, Edwards syndrome, trisomy of 18, Patau syndrome, trisomy of 13. So let's just get right into it. Firstly, intellectual disability is going to be present in all of them. In addition, Down syndrome patients will have a high risk of getting early onset Alzheimer's because they have an additional copy of chromosome 21, which codes for the amyloid precursor protein. And the accumulation of this plays a role in the pathogenesis of Alzheimer's. Secondly, when we look at the head, Down syndrome patients are going to have flat faces with prominent epicanthal folds and brush field spots in their iris. Edwards syndrome will present with a prominent occiput, low set ears, and micrognathia, which is a small jaw. Patau will show holoprosencephaly, which means that the cerebral hemispheres won't divide properly. And that is a very important thing to remember for Patau. There can also be microphthalmia and microcephaly, small eyes and small head, cleft lip, or palate. Coming to the hand, Down syndrome patients will characteristically show a single palmar crease with an incurved fifth finger. In Edward, you must remember, because it's super high yield, that the babies will have a clenched fist with overlapping fingers. Patau can show polydactyly, which is more than 5 fingers or toes on their hands and feet. In the heart, Down is very, very likely to present with atrial septal defect or ventricular septal defect. Edward can also present with a ventricular septal defect. Patau congenital heart diseases are present, but I didn't come across a specific association. But yes, it can present with different congenital heart diseases. If there's any specific association that you know, please do let me know in the comments below. And coming to the GI tract, Down syndrome patients might show duodenal atresia. Now, during the development of the duodenum, there comes a point where it epithelializes and blocks the lumen. Eventually, it also recanalizes and the lumen is free. But in case of duodenal atresia, this recanalization doesn't happen, so it remains blocked. So that can happen in Down syndrome, or Hertzsprung disease can occur. In Hertzsprung disease, there's basically failure of neural crest cell migration, and there's going to be a lack of myenteric plexus, the neurons that help in the movement. And because there is a lack of that movement through the intestines properly, proximal to the aganglionic part, there will be a dilation of the segment of the colon, and this can eventually cause a congenital megacolon, and chronic constipation will be present, and the baby will not pass meconium within 48 hours. So, yes, this can present in Down syndrome. Patients with Edward and Patau can show omphalocele, which is the herniation of the bowel through the umbilicus, and this bowel portion is going to be contained in a peritoneal sac, in contrast to gastroschisis, which is a para-umbilical herniation and it's not covered in anything. That was just to remind you here, but these particular genetic disorders are associated with omphalocele. And the feet of the baby in both Edward and Patau can show rocker bottom feet. I'll just show you a quick picture of rocker bottom feet. So this is how they look like. And moving on, in Down syndrome, it is very likely that the patient can go on to develop AML or ALL leukemias. In Edward, the patient can present with myelomeningocele, which is the herniation of both the meninges and the spinal cord through a defect in the back. And they usually, unfortunately, die by the age of 1 year. In Patau, they can present with cutis aplasia. That means a portion of the scalp can go missing. It can just not be there. They can have polycystic kidney disease. There can be a defect in diffusion of precaudal mesoderm. That means the thing that you have to remember is that there are midline defects, and this is where holoprosencephaly also comes from. So the reason why these trisomies can happen is very likely due to meiotic non-disjunction. In the case of Downs, if not meiotic non-disjunction, it can happen due to Robertsonian translocation or post-fertilization mitotic errors, and it can also show a pattern of mosaicism. And now coming to the markers, particularly in Down syndrome, beta HCG is going to be increased in both trimester 1 and trimester 2. In contrast to the other trisomies, where beta HCG is less in both the trimesters. In fact, if you look at Edwards and Patau, everything is going to be less in these diseases, all the markers that are supposed to come during pregnancy. So, the first box with beta HCG and pregnancy associated plasma protein, you'll check these in trimester 1, and in trimester 2, in what is called quadruple screening, you look for beta HCG in T2, inhibin, estriol, and alpha beta protein. Now, in Down syndrome, both beta HCG in trimester 1 and 2 and inhibin in trimester 2 are going to be elevated. Everything else is going to be lesser only. So, this was about all the trisomies, and I hope this quick review helped in maybe a pre exam cram session. Either way, thank you for watching and all the best.